Okay, so good afternoon, good evening, sorry, and namaskar, everyone. Welcome to this, our very first Hindu Bengali webinar on kidney and related health matters and organ donation. I am Bashir Riaz, your chair today, and apologies from Nurja Jain, who sadly had to visit her father, who's been taken seriously ill. So please do remember him in your prayers today. I work as the Scottish Peer Educator Project Coordinator at Kidney Research UK. My teams and I would normally be doing this vital awareness raising across the UK face to face, but of course, COVID-19 has put a stop to that. So undeterred, we have now found a new novel way of doing this. I'm really grateful to Dr. Santanu Acharya and Bangia Sanskritik Parishad in Glasgow for supporting and co-hosting this unique event with us. Also, many thanks as always to our fantastic funders, Scottish Government. You'll hear more from all of them and our other brilliant speakers shortly. You'll have opportunities at the very end of the talks to ask questions of any of our esteemed speakers. Just to say that this webinar is being recorded so that we can share with many more people afterwards. There are also 3 questions in the chat bar that I've just posted, so please do take your time out and answer them. And this will provide us with greater feedback and comments for future webinars. Thank you. Finally, you may wonder why we, as Kidney as Charity, are so involved in a subject about organ donation. It's because many of you may know, but the vast majority of people waiting for an organ transplant are waiting for a kidney. As a research charity, we are focusing on research to make transplanted organs last longer and better. For more information, you can visit our website on www.kidneyresearchuk.org. So on to our first speaker, Dr. Santanu Acharya. He is a consultant gynaecologist and obstetrician working in University Hospital Crosshouse and Glasgow Centre for Reproductive Medicine. He's a trustee for possibly one of the oldest ethnic minority organisation in Scotland, the Bangia Sanskrit Parishad, BSP. He's honorary senior lecturer, University of Glasgow, and also works for the Royal College of Obstetricians and Gynaecologists and General Medicine Council. His passion for charitable work has led him to institute a project for collaborative action for lowering maternal death, CAMD, in reducing maternal mortality in low-resourced countries. He was bestowed with highest honour Paul Harris Fellowship by Rotary International and Global NHS Citizen by the Scottish Government for his work. He is also a patron for the Fit for Fertility programme, which is funded by His Royal Highness Prince of Wales Charity and Dumfries House, helping women with fertility issues. Over to you, Dr. Santanu.
Good evening, and many thanks, Bushra, for your kind introduction. I'm hoping to see many participants today for this evening, which is a topic very close to my heart. Now, many in the audience might think why there is a gynecologist amongst these eminent speakers, and they're right in a way. But obviously, my closest association with organ donation, after all, is with eggs and sperms. With basically, we have a test tube baby which I work in. But rest assured, that's not what we are discussing today. Coming back to the point, this topic has always interested me since I was young. I fondly still remember those days in Calcutta where I originally come from, and Bangia Sanskrit Parishad is one of the Bengali organizations predominantly, but I'm aware that today's speakers as well as the audience would be kind of non-Bengalis as well. But hailing from Calcutta, I still remember 2 days in a year which I religiously always used to follow. One being the 5th of January, which used to be the Sir Frank Worrell Day. Some in the audience who are as old as me may remember that Nari Contractor was a famous Indian cricketer who was hit on the head by a ball by Charlie Griffiths during India's trip to West Indies in 1962. And he needed blood transfusion for head injury. And apart from 3 of his teammates, opposition team members, captain was Frank Worrell, who visited Nari in the hospital with Charlie Griffith, and both of them donated blood. Unfortunately, a few years later, at the age of only 42, when visiting India again for another trip during the cricket trip there, he was diagnosed with blood cancer and died shortly afterwards. The Cricket Association of Bengal actually organized blood donation camps in his honor since 1981. And such acts of camaraderie and sportsmanship always inspired me.
Dr. Santana, sorry to
Yeah.
disturb you. I think there's a problem with the here that you're.
Audio?
Yeah,
Right.
because I think a lot of people were saying you couldn't hear you. So just maybe it's just your headset.
Okay.
Is that better?
Is it any
Yeah,
better?
yeah, that's better. Yeah. Thank you.
Right. So I was kind of talking about how I got interested in kind of donation, and that was mainly about the.
If you just bring it closer to your I think it's that's it. Yeah.
Hello.
Yeah,
Is
that's
it any
better.
better?
Yeah, that's better.
Okay. Right. Technology.
Yeah, it's okay.
So Frank Worrelday is. I'll probably just get the thing out. Without that. Is that better? Okay. Right. Yeah. So I was kind of talking about Frank Worrelday, which is kind of something very important in the Indian or Bengali calendar in Calcutta. So Nari Contractor was one of these cricketers who was part of the visiting team going to West Indies for cricket, who was hit by a ball from Charlie Griffiths, and he needed head surgery. And at that time, basically Frank Worrell was the opposition team's captain, along with these 10 members came and donated blood. And unfortunately, only a few years later, when he came down to India to play cricket, he was diagnosed at the age of 42 with blood cancer. And then subsequently, he died. But to commemorate him, Cricket Association Bengal always is to do this annual Sir Frank Worrell Day blood donation camps, which I was always used to visit. The other day was the 16th of August. Again, people in the audience who come from Calcutta would remember that this is one of those dark chapters in Calcutta where one of the biggest derbies in Indian soccer is Mohun Bagan and East Bengal. And they were playing a derby when almost 16 people died during a stampede. And that again was a blood donation camp, which we used to go, and I religiously always used to kind of attend to donate blood. Whilst studying medicine, many of us actually got in close to an organization called Gono Dorpon again, which was an NGO, which inspired many of us to donate our body when we were medical students in India many years ago in the last century. But I did so again when I came to the UK, and it's so easy to do. It's one of the biggest gifts you can ever give. And it's important to remember that as ethnic minorities, we need kidney transplant, for example, twice as likely as our white counterparts. And very rarely we donate. So we'll hear from Jay and Sina later on that this is one of the biggest gifts you can give. And it will be successful at least if one person, after having today's kind of being through today's webinar, if one of us kind of donate that. Without much ado, I'll probably proceed with next part of the program. And Bushra, you can invite the next speaker, please. Thank you.
Thank you, Dr. Santanu.
You're
okay.
muted, Bushra.
Oh, can you hear me now? Hello, you can hear me now? Yeah. Okay, sorry. Thank you very much, Dr. Santanu. That was a great short summary about the work that you're doing.
You're still muted, Bushra.
Can you not hear me?
No, we can't hear you.
I can hear you.
Yeah, you can hear. Yeah. I think you can. I think it was just probably, yeah, we can now. Okay, sorry. Thank you, Dr. Santanu. The next speaker is myself. I'm Bushra.
We can't hear you, Bushra.
No, you can't. Can you hear me?
We all can hear you.
We all can hear
you. Yeah, I think Dr. Santanu is yourself. You need to put your microphone in.
Headset.
Yeah, if you put your headset on. Hold on. It's okay. I think when Dr. Santanu took his headset out, I don't think he can hear. Yeah. Can you hear me now, Dr. Santanu? Yeah, I think it was when you took your Santanu, sorry, your headset off, Dr. Santanu, you couldn't hear me, everyone else could.
Okay.
Anyway, sorry. So myself, I am Bishra Diaz. I'm the next speaker. I am the peer educator coordinator for the Volunteers for Kidney Research UK, the organ donation project in Scotland. I'm a graduate in management and maths and hold an MSc in marketing. Having worked full-time within marketing fields for many, many years, I took some time out after my third child, and I then became a volunteer with the Kidney Research Charity. I was then recruited on a part-time basis as a coordinator for the volunteers known as the peer educators. And now it's been approximately 4 to 5 years now I've been with the charity, and as Nirja says, I'm a great asset. So without further ado, I will just go on to my presentation. Okay, so the South Asian Organ Donation Project. Who are Kidney Research UK? We are the leading charity which is committed to developing treatments on patient information and raising vital public awareness to help save lives. Every year, an estimated 60,000 people with kidney failure are alive today because of the advances in research that we have directly contributed to. With our research breakthroughs, more kidney patients and their families have a chance for a normal life. We have many things on the website that are available for kidney patients, like Kidney Beam, and like we stated before, please do visit our website for further information. So what is kidney disease? It is a silent killer. There are 3 million people in the UK just now with it, and there is no cure. Kidney failure is up to 5 times more common in people from the BAME, which is the Black, Asian and minority ethnic communities. Asian people with diabetes are more likely to get kidney failure than white people with diabetes. And the 2 major causes of kidney disease are of diabetes and high blood pressure. So what was the need? We found that the BAME groups represent 14% of the UK population. And the South Asians, that is the Sikh, Hindu and Muslim communities, are 7.5% of the population, which is the largest group. The registration on the NHS ODR, which is the Organ Donation Register, was very low within our communities. And many of them are unaware of health issues such as diabetes and high blood pressure, which is very common in South Asian communities. We are more likely to need a transplant and less likely to donate, and hence more likely to wait longer for a donation. There's lots of misinformation on, for example, like operation guidelines, myths of mutilation. There's lots of cultural and religious misconceptions and lack of knowledge. And we found there was a lot of language barrier between the communities as well and the NHS. So this gave birth to the Scottish Peer Educator Project. We were initially funded for a 2-year project, the Peer Educator Project, in 2013. This is now, we are now into our 7th to 8th year, and this is about raising awareness within the Hindu, Sikh and Muslim communities on kidney disease, the change of law, and how to support those with kidney disease. So the peer educator, we have engaged with over 6,500 people in the 7 years that we've been working. We've had over 1,000 people sign up on the NHS OD register, and 1 donor can save up to 9 lives. There's more awareness and discussion taking place. There's lots of inquiries and discussions, and our Scottish project has been the most successful in the UK, winning many awards such as the SEMVO and Scottish Asian Business Awards. Just some pictures about the peer educator volunteers at the different events, such as community events, gurdwaras, temples, mandirs. Thank you very much. Kidney disease ends here. So, without further ado, I will now go on to our next speaker, who is Dr. Rajni Tajwani. I will just bear with me. I will just get right. Dr. Rajni is a consultant physician with a special interest in nephrology, i.e. the kidney, at University Hospital in Hairmyres in NHS Lanarkshire since 2013. She did her specialist training in Sheffield and Glasgow. Rajni's special interests are in medical education and raising awareness about identification and management of acute kidney injury. I'm delighted to also say that she's a volunteer with Kidney Research UK. So if I just, get your screen share and get your PowerPoint. Oh, excuse me. Oh, sorry, excuse me. Just apologies, Rajni. I'm just screen sharing with you now. Yeah. Right, that's us now.
Many thanks, Bushra, for your kind introduction, and thank you very much to Bangya Sanskritik Parishad for asking me to talk today in this webinar ahead of World Kidney Day, which is on 11th of March next week. And I'm quite privileged to be raising awareness about the South Asian kidney health and disease. Oh, I can't move my slides, Bushra, sorry. So I would just like to start with function of kidneys. So what do kidneys do? Most people are born with two kidneys, but still can function with one kidney. And that's how they can donate one kidney to someone who needs a kidney transplant. Healthy kidneys, they cleanse the blood of toxins and transform that waste into urine. Kidneys manage water and chemical balance in the body and help to control blood pressure, and they produce hormones which are needed for formation of red blood cells and are very important for good bone health. So kidney disease can be divided into two types. Acute kidney injury, as the name suggests, happens very acutely over a short duration of time, and usually it is because of some other illness, but sometimes it could be related to problem inherent to the kidneys. Many times this acute injury is reversible and people completely recover their kidney function with proper treatment, but unfortunately on some occasions it doesn't happen and people end up needing kidney dialysis or transplant later on. Second type is chronic kidney disease. As the name suggests, chronic happens over a duration of time, and this is identified by doing a blood test, which we look at two figures. One is creatinine level, and other figure we call as EGFR, which represents glomerular filtration rate, electronic. So when we see reduced EGFR, we say patients have got kidney disease or chronic kidney disease if that has happened for more than 3 months. The stages are progressive from 1 to 5, 5 being the worst. And during this time, steps can be taken to slow down the progress to stage 5. And once patients stage or arrive in stage 5, then they need dialysis or kidney transplant, usually to sustain life. Usually there are no symptoms at first because like diabetes and hypertension, it all goes silent and patients present an advanced kidney failure. With acute kidney injury, usually you will have symptoms related to the underlying cause for it. But when it is chronic kidney disease, as the disease progresses, people pass less amount of urine, they get swollen ankles or feet or hand, and they feel very tired. They lose their appetite and start losing weight without even trying. They feel quite nauseated and are sick at times, have headaches, and they suffer with poor concentration. In quite advanced stages, they have got severe itching and very dry skin. So once we arrive in stage 5, we start talking about some other methods that will take over the function of the kidneys to replace the kidney function. So it is called renal replacement therapy. And this is provided by different ways. One is dialysis. Again, dialysis is of two types. One is hemodialysis, which is done through a machine. So what we do is take out blood from the body, filter it through a machine, and pass the filtered blood back into the body. The second type is peritoneal dialysis, when huge amount of fluids are put in the tummy through a tube which has been inserted surgically in the tummy. Let that fluid rest in the tummy, and then dialysis happens inside the tummy, and then the fluid is drained out with all the toxic substances. The most common or the most favored option and happier option you can see from the photo is the kidney transplant. And kidney transplant can happen from a living donor, usually a relative or somebody else. And I'm sure later on in the slides you will see how or what are the other modes of transplant. Or otherwise it is cadaveric transplant, that is people who have died, they will donate their kidneys and those will be transplanted in the kidney patients. Sometimes we can arrange hemodialysis at home for the people who are able to look after themselves and can take the responsibility of doing the procedure for themselves. Peritoneal dialysis is a home therapy. Unfortunately, some people who are elderly have got severe heart disease. They might not be suitable for any of these treatments, hemodialysis, peritoneal dialysis, or even transplant. And we just try to manage their symptoms by using different kinds of medications and try to improve their quality of life. What are the specific points related to kidney disease in South Asian population? So, as Bushra was telling you, some of my, I'm just reiterating these points and numbers. So, diabetes and hypertension are much common in Black, Asians, and minority ethnic population. And again, that becomes more common cause. So, if you're a South Asian with diabetes, you've got 10 times more chance of getting into advanced stages of renal failure and needing dialysis and transplant. Many times we see that people from our community, they present very late in end stage kidney failure. Many times they are obese, and obesity itself is a risk factor associated with kidney disease. More commonly, we see non-compliance issues and non-engagement of South Asian population with the health services. There are language barriers and there are limited resources about the diet restrictions for people with diabetes, hypertension, CKD, or dialysis, because there's not much information about how much protein or how much potassium is in bhindi or other stuff which we commonly eat. And there is usually very poor uptake of home therapies, that is home hemodialysis and peritoneal dialysis in South Asian population. Other factors that affect South Asians are holidays. So once you're on dialysis, there are quite advanced restrictions to travel, and then we find it difficult to go back home where we can't arrange dialysis, or even wherever we plan to take holiday. And when we travel back home, there are higher chances of getting blood-borne virus infections and also reactivation of some of the infections which are specific to Asian continent, like TB. And this is just because all patients with advanced kidney disease or on dialysis or who have had transplant, their immune system is very, very weak. Some people who wait for a long time for dialysis actually travel back home to get kidneys because it's probably easier to get a kidney there. And then they come back, and usually it has got its own implications and problems. They come back with nasty infections or poorly matched and poorly functioning kidney. What about organ donation in South Asian communities? As Bushra was telling you earlier, that South Asian population accounts for 7.5% of UK population, but there is disproportionately low representation from our communities on the organ donation register. Lots of misinformation is there about the law behind it, but you'll get more information about the new Scottish law and more detailed information about it in few next topics. Misinformation related to the operations or mutilation or even delay in funeral, these things also tend to affect decisions of the family of the loved one who's dying. Then family takes decision not to donate their organs. There are lots of cultural and religious misconceptions, and we are trying our best to try to get over with these misconceptions. There's very poor link for community members, and the webinars like this will help us to overcome that as well with help of Kidney Research UK and all the community involvement. We are very poor at discussing death, organ donation, advance directives, and our wishes amongst our family members who are actually going to discuss with the doctors later on when we die as to what should happen and if we had conveyed that we wanted to donate organs. So for this reason, relatives already, they're sad, but they get confused as well as to what to do in those situations. So what happens because of all these reasons? We are more likely to need transplant for our community. We are less likely to donate. We wait longer on the transplant list and have poorly matched kidneys, which causes poor quality of life and ultimately have shorter lifespan. This is a data from 2019 and 20 organ donation. I don't know if you can see very clearly on this, but what it shows is 1% of people who die each year are eligible for donating their organs, and out of those, 5% are Asians. In South Asians, only 36% of family members will agree for organ donation, although in white population, it's 71%, so nearly half of it. And 3% of all deceased donors are Asians. People who are waiting on the transplant list, the number is rising, and there has been about 3% increase in last 3 years. And once people go onto the transplant waiting list, what happens in the next 1 year? So 3% die, only 28% get transplant, and more people, around 66%, are still waiting to get the transplant, and some of them are taken off the dialysis list because they become more unwell and would not be suitable to get a transplant. So what do we need to do? We need to identify kidney stage at early stage so that we can prevent the progression of kidney disease from stage 2 or 3 whenever we find it to stage 5 and delay the need for dialysis really. Once we are diagnosed with kidney disease or diabetes or hypertension, which are the major causes of kidney failure, do their optimal monitoring and effective treatment and control these risk factors. We need to work towards timely and planned renal support so that people start dialysis on time, or they get onto the transplant list in time and get transplant a bit sooner rather than later, or just for years keep on dialysis rather than getting a transplant. We need to have better discussions with our loved ones about our wishes to donate gift of life so that it's easier for them to fulfill our wishes after our death. We need to get improved representation of Asians on the organ donor register, and also we need to develop more community links and raise awareness about organ donation. I would like to end my talk by thanking Kidney Research UK and Bhagya Sanskrit Parishad for giving me opportunity to speak today, and also thanking other speakers and all attendants today for this webinar. Thank you very much.
Thank you very much, Rajni. That was amazing, great insight into the health of the South Asian communities. Okay, next up is our next speaker, who is Mr. Ankar Mukherjee. He is a urology trainee currently working in the northeast of England. His mother has had renal failure and initially had a kidney transplant in 2011. Is now back on dialysis waiting for transplant. He will be speaking about his personal perspective about the time when his mum, through his mum's renal failure. So over to you, Ankar.
Thanks, Vishra. Do you have my slides?
Yep, if I just, just give me 1 second now. Yeah, I'll just share screen. And I will. Okay.
Okay. Can everyone hear me okay?
Yep.
Great. Thanks, first of all, to Kidney Research UK and Bangladesh Sanskrit Parishad, especially Shantanuda, who approached me earlier about talking, I guess, on a personal perspective regarding my mother, who had a kidney transplant in 2011. Obviously, initially, it evoked a lot of different emotions and range of emotions, actually. And I guess today I'm going to be talking purely with a personal hat on, without the medical involvement at all. And what it was like for us as a family, for her to go through, I guess, a chronic disease process which led her to having a transplant, and then subsequently having the transplant, and then, I guess, a bittersweet effect of actually going back on dialysis again fairly recently. So I guess without further ado, I'm going to start the talk. I can't seem to progress my slides along. Oh, there we are. So I guess in a way, regarding personal perspectives, I guess my mother as a whole, within our community as well as within our family has been a very strong character. Whoever knows her will probably vouch for that as well. She's a fiercely independent person, and she's very, very active and social, and often considered the life and soul of a party. I guess for her to undergo sort of a chronic disease process and eventually lead to having a transplant, it had a sort of effect on her sort of mental well-being as well, but also physical well-being. But I guess more than a kidney transplant recipient, I see her initially as a mother, an artist, mother to 2 boys, myself and my brother, my father, who's a doctor, and also within that context as a first-generation South Asian migrant in this country. So I guess that kind of builds into the picture of someone undergoing a transplant and what it feels like for them and their family to go through that. Life before the transplant had been, she had a chronic disease which we knew about, which was under control. And because the diagnosis was at a young age, she had to make a lot of sacrifices in her life with regards to going out or essentially diet, some restrictions in physical mobility, jobs, etc. And she was quite adept at going to clinic reviews and regular hospital visits and things. But eventually nothing really prepares you when you have to have a news to say that unfortunately your kidneys are not doing great at all and you will have to have some sort of renal replacement therapy, which Dr. Tejwani talked about briefly before. And obviously we were prepared for that, but that discussion and dialogue with her renal physician, I remember going with her in the clinic, and it was quite tricky. And she felt as if there was some, it was difficult. And I think she was expecting a lot of tiring, strenuous, arduous processes, which she did go through. And she had about 9 to 10 months of dialysis initially in the hospital and then transferring to home. Within that process, my dad actually was imparting the dialysis treatment at home. So he had to learn a lot of things at home. There were some unexpected events, such as fainting and her blood pressure crashing and feeling bad. So I guess we were all sort of wanting her to have a transplant as soon as possible, hoping or wishing that she would have a likely donor. She had to make a lot of adjustments, and I guess she continues to make a lot of adjustments regarding her lifestyle because she's back on dialysis, as I said. So she has a lot of restrictions, as do we all, given the current pandemic. But if you have to live with this for the last 7 to 8 years, it feels like that, living in a pandemic for a long time. And essentially diet with fluid restrictions and food that she eats. As I said, she's a very social person, a very life and soul of the community, as it were. So I guess meeting and socializing, she never really lets anyone know what she's going through mentally. But we can kind of assess, at the end of the day, she does feel very, very tired and strained and exhausted. So amongst all this, we were wanting some sort of an end in sight with regards to an outcome such as a transplant. And I guess as she is quite a social person, she likes to talk to people, and she built a very good rapport with the dialysis staff at the unit. And like all renal patients do, they have a very personable relationship with a lot of healthcare workers in the hospital, and they trust them implicitly with everything. And we're very grateful for that, absolutely, with everyone that was at initially the Western Infirmary in Glasgow, which is now closed. And essentially, she was having a reasonably good quality of life, but obviously we wanted her to have a transplant as soon as possible, if it could be possible. And lo and behold, there was a phone call which was made at late night, and I still remember the day. It was the first week in September when all the schools went back. And we got a phone call from one of the transplant surgeons and one of the coordinators in the Western Infirmary, stating that there's potentially 3 recipients, and she's one of them. And if she could come to hospital the next morning, very quickly, and potentially she could have a transplant as soon as the next day. Now, what was slightly odd was I was working as a junior doctor at the time in the same hospital and in the same unit. So obviously that I had a lot of different feelings running through my mind at that time. However, I didn't sort of let that bother me too much and just went with the flow and tried to support my mum as much as possible through this process. And as I said, it was the first week of September, so I remember my brother having to start secondary school at that point as well. So the house was in a bit of a turmoil as to what's going to happen, etc. She went the next day, and there was a lot of blood tests done with tissue typing and matching and donor matching, etc. And the decision was made very late at night to have her go forward for the transplant. And I distinctly remember her asking me that, so what will happen to the other 2 who were with me, and they will not receive it. And I guess that question always stands from, as South Asians, we always have a very sort of, she comes from a very caring background, and she has a kind of motherly tendency to want everything good for everyone. And the fact that she was quite elated and happy that she was going ahead for the transplant, but she also had the back of her mind, what's going to happen to the other 2? I mean, that's what happens, I guess, when you go through that process. Essentially, the transplant, I think, happened late at night, in the early hours of the morning. And we were told around about 5 or 6 a.m. that it was all complete and she was going to be assessed very closely. And there was a tedious and time immediately post-operatively with several blood tests indicating that she had a bit of rejection, as can happen with a lot of patients who have a lot of antibodies. But it was well controlled with medication and it settled down over time. And there were several checks and balances that were made that were protocol within the transplant unit to make sure that she was essentially healthy and functioning okay. I guess the feeling that she had soon afterwards was a sense of gratefulness and joy and elation and kindness and gratitude to the person who essentially donated their kidney, who we believed was a young gentleman who had unfortunately succumbed to a fatal accident. And I guess she protected her kidney very, very, very carefully with doing a lot of careful diet control, ensuring that she takes the right medications on time, and extremely protective of this new organ or life that she had been given. And as a family, we were understanding of that too. I guess it has been around about, well, her transplant was successful. However, it did end up not working as well. And she is back on the dialysis over the last 1.5 years or so. And she's actually back on the transplant register as well. But it's given us a new sense of purpose and a new sense of gratefulness to the organ donation system. And I think within our South Asian community, we have to not only engage, but create a dialogue with everyone in order for us to, I think there's a lot of awareness, but I think the dialogue is perhaps not lacking. And dialogue doesn't just mean from large organization, it means a communication in a reciprocal way. So answering questions and answering queries and allowing people to understand why it would be such a great thing to do for a transplant, and giving someone a new life, essentially. And I think that dialogue needs to come from our community as well as the organizations which are trying to support this excellent system. We are eternally grateful for the care that she received, and she continues to receive, actually. And she is extremely, extremely grateful for that. And I think whatever work we can do, or whatever we can do in our capacity as family and as sort of individuals who've been benefited by this process indirectly, then I think the more dialogue we have, the better it is. So yes, organ donors save lives, and I think that message needs to come across very strongly. But rather than just awareness, I think a dialogue is very, very important, because often it weeds out any misconceptions within our own community that we have, and that's very important. So once again, thank you very much, Bushra and the Kidney Research UK and Bangladesh Scientific Parishad for allowing me to talk. Very grateful indeed, and I hope your work continues to flourish.
Thank you very much, Ankar, for your insight, and I'm praying that your mum gets a call soon for her transplant, and the impact that it has. Okay, sorry, I'm just mindful of time now. So on to our next speaker, who is Fern Morris. Fern Morris is a policy manager working on implementation of the opt-out organ and tissue donation system for Scotland. She has been at the Scottish Government for over 10 years with experience in ministerial private office, alcohol policy, and most recently working on the development of the legislation for the opt-out system. So if I just get your slides, Fern. Sorry, just I think my laptop's got a mind of its own today. Just 1 second, I've got your slides up now. Oh. Okay. I will, okay. Over to you, Fern.
Okay, I can't see the controls, Bushra.
I don't know.
Along.
Yeah, I've just sent the controls to you, so I'll do it again for you just now. So there you go. Has it gone through?
No.
It's okay. I'll swap your
slides
for you.
Okay. Hi everyone. Thanks. Thanks, Bushra, and thanks for inviting me here tonight to speak to you about the law change. We're just over 3 weeks away to the law change on the 26th of March, moving to an opt-out system. So it's really good to be able to come to events like this and speak to people about what the law change means. So I won't speak for too long, but I'll just speak a bit about the approach that we've taken to the law change, why we're changing the law, and also what it means for people and what we're asking people to do. So I guess the most important thing about the approach we've taken when developing the legislation for the opt-out system is that we've tried to retain the element of donation as a gift. That was really important as we were developing the legislation, to ensure that the notion of a gift wasn't lost as we move to the opt-out system. We know what a tremendous gift a transplant is when somebody is able to receive one, and we know that a large part of that is because it comes at a time of great tragedy for a family coming to terms with the loss of their loved one. I know we're going to hear a bit more about that later this evening. And what we've sought to do in the legislation is to reflect those conversations that take place at the end of life, and to really put the donor's views at the heart of those conversations and make sure it's the donor's views that are prioritised, to make sure that even though we're moving to an opt-out system, that donation doesn't go ahead where it would be against the donor's wishes. So moving on to why we're changing the law, well, we know that there's a lot of support for donation in Scotland. So from surveys we undertake, we know that around 90% of people support donation, are willing to become a donor, and that's due to a lot of hard work that's gone on over the last decade or so, awareness raising about donation, events like this, trying to raise awareness about what donation, what kind of difference to people's lives donation can make. But despite that really strong support, we know that a lot less people get around to actually going on the register and signing up to become a donor. So about 50% of Scots are on the donor signed up to be on the register signed up to be a donor, which is still really good. It's a really high proportion, but it's a lot less than people are willing to be a donor. And all the while, as we've already heard, only about 1% of people die in circumstances where they can become an organ donor. So that means dying in intensive care. So there's quite a limit on who can, the number of people that can become donors. And all the while, we've got around 500 people waiting for a transplant in Scotland at any one time. And again, there's been a lot of really fantastic work gone on to try and reduce the transplant waiting lists, and things are moving in the right direction. But it's important that we do everything we can to try and improve the chances for people who are on the transplant waiting list. So one way of doing that is to look at how donation's authorised and move into an opt-out system rather than an opt-in system. So I'll just talk a bit about what the new law actually means. So the first thing to say is that people still have a choice. So just as you can now, you can opt in to be a donor. If you want to make that choice to be a donor, you can opt out. It's a very personal decision, donation, and we want everybody to make the choice that's right for them. So if you don't want to become a donor, you can opt out just as you can now. What the new law means is that if you do neither of those things and you die in circumstances where you could donate your organs or tissue, then the assumption will be that you're willing to donate. But importantly, there are checks built into the law, into the system, to make sure that nobody becomes a donor if they wouldn't have wanted that to happen. So as part of the law, there has to be a conversation with the family to find out what the donor's views were, and to make sure if they didn't want to donate, that donation doesn't go ahead. Also, there are certain protections for certain groups of people who might not be able to understand that or might not be aware about the new law. So it won't apply to children, so under 16s. It won't apply to anybody who's been resident in Scotland for less than 12 months. And it won't apply to anybody who wouldn't be able to understand the new law, just to make sure that there's protections for those groups of people as well. People in those groups can still donate, but it won't be assumed that they're willing, so they can only donate if they've opted in themselves or if a family member authorises donation on their behalf. And the final thing to say is about the tests. So as part of the law change, we're making it clear that as part of the donation process, there are certain tests, things like I've already alluded to, like blood tests and urine tests that take place to try and match a donor to somebody on the transplant waiting list, to make sure that they can get an organ that is a good match for them and is healthy and it will be safe for the recipient. So as part of the new law, we're making it clear that those are part of the process and will be part of the process if people become a donor. So in a nutshell, that's what the new law is. And what we're doing at this point is letting everybody know about the law change, trying to let as many people know as possible before the law changes at the end of this month. So we've got a campaign running at the moment. You might have seen the adverts on TV. You've hopefully got your leaflet through the post. Leaflet's been sent to every household in Scotland to make sure people are aware of when the law change is coming, what it means for people, what their choices are and how they can record a decision. And our kind of main message as part of the campaign is make that decision, record it on the NHS donor register, and also tell your family about it. We've already heard about the importance of that dialogue, and that's really important because families will be involved at the end of life stage, and they will be asked about their loved one's views. And we know that if families know what their loved one wanted, it makes it so much easier for them to have that certainty of what they wanted, rather than to be guessing. So our key message: make your decision, record it, and have that conversation with your family. Thanks, Bushra.
Thanks very much, Fern. That was great insight into the change of law. Without further ado, we'll move on to our next speaker, Jane Lumsden, who is a trained nurse who has worked in various medical specialties, and following 4 years as an intensive care nurse, commenced the role of a multi-organ donor transplant coordinator in 1997. Jen completed her PhD with the University of Edinburgh with nurse-led research into quality of life issues in living donor kidney transplantation in 1996, with several peer-reviewed publications focusing on living donation. She has specialised in this field for the past 20 years and is working with the Scottish Government to raise awareness and improve equity of access to information in Scotland about living donor transplantation. Hi, Jane.
Hi, thanks very much, Bushra, for that lovely introduction. Thank you.
I will just get your slides.
Can you see and hear me okay? I've had a bit of a problem with my camera this evening. It wouldn't go on, but I think I've gone out and come back in. It's all on, is it?
Yeah, it's fine now. We can hear you now. I will just get to screen share you.
Lovely.
Okay. And I'll see if I can get you. Right.
Thank you very much, and thank you again to Kidney Research UK for inviting me to this event, the opportunity to talk to you about living donor kidney transplantation. Don't seem to.
Yeah, I'll move it on for you.
So we're very proud of our history in Scotland of living donor kidney transplantation. As you can see from this Scotsman headline from 1960, we did the first successful transplant between twin brothers on a Sunday in 1960. And this was really the start of a complete change of treatment for people with kidney failure. Dialysis had just been invented and transplant was coming about. And now we're at the stage, next slide, thanks, that in Scotland we do over between 400 and 500 transplants every year, which is just fantastic, life-changing, life-saving for people. And it's something, as a transplant coordinator, seeing people waiting on the transplant list and then seeing them afterwards, and it just every day reminds you what a tremendous gift and what a difference it makes to people's lives. Next slide, thanks. So the options, as we've heard already, for somebody who has got kidney failure, they can consider going on hemodialysis or peritoneal dialysis, but really, we want every single person who's needing treatment to be considered for transplant. And it might not be the right thing for some people, that might be too risky, the operation might be too big, it might not be in their best interest. But for people who could benefit from a transplant, then that is something that should be explored before even discussing dialysis. Next slide, thanks. So a transplant from a deceased donor, the average wait is 2 years, and there's a 75% patient survival at 10 years, which is why we are very, very keen that everybody explores living donation as the first option. It can be organised before needing dialysis, and we have a 90% patient survival at 10 years. So for somebody with kidney failure, a living donor transplant is the best option and should be considered first. However, for a living donor transplant, you need a living donor, and that is not an easy thing to ask. So one of the initiatives that we're doing is to really try and raise awareness of both directed donation, so people who are waiting for a kidney, their family members and friends have heard about living kidney donation, but also altruistic donation. When the law changed in 2006, complete strangers were allowed, people are allowed to come forward and donate to a complete stranger. And that's really been a game changer in living donor kidney transplant programs throughout the whole of the UK. Next slide, thanks. So what do we do when somebody comes to us who is approaching end-stage renal failure? And it's a very difficult thing just to send somebody home and say, now go and speak to your family and discuss who wants to give you a kidney, because you're asking somebody to go through a major operation. They could have a lot going on in their life. There can be family dynamics that make that very difficult. So as much as possible, we support people with discussions in the family, with raising awareness. We give everybody this a red pack to go home, so there's no pressure on anybody to donate. Some people are fortunate, some people are fortunate and have family members many family members who come through, and then, you know, we need to speak to all the family members, perhaps do their blood group and tissue type to check who'd be the best match, but also who's in the best situation to go through an operation, who's going to be fit enough to not have any, you know, short or long-term complications. So all these things are taken into account. The risks and benefits are very, very important when they're discussed in great detail. And, you know, nowadays, when I first started as living donor coordinator, if somebody came forward and they weren't a match, then we just had to send them away. Nowadays, we have many different ways of finding how we can move forward, either with a two-way exchange. If a donor isn't compatible with a recipient, then we can find a recipient who is compatible with that donor, and their donor donates to the recipient. We have the altruistic donor starting off a whole chain of transplants. So as you can see here on our chain, you have an altruistic donor donating to recipients. So an altruistic donor in Edinburgh donating to a recipient in Glasgow, their donor donating to a recipient in Newcastle, and their donor donating to a recipient in London. And so you have 3 kidney transplants happening on that one day due to an altruistic donor. So, you know, that has been really fantastic progress that we've made in living donor transplant. Next slide, thanks. A transplant, the most important people in a transplant are the donor and the recipient, but they do need a bit of support to get to that point, not least the surgeons to do the operation. But there's a whole team of people, and as you can see here, this is just some members of our transplant team in Edinburgh. A whole team of people, and that's actually what comes through, we hope, to the recipients, to the donors, that we have people looking after each person. The donor team makes sure that the person who is wanting to donate a kidney is fit and healthy, that their kidney function has been fully assessed by scans and x-rays, etc. All the different people in the team discuss the results to make sure, as much as possible, the risks to the donor are both short-term and long-term are really minimal. And, you know, often people come forward wanting to donate a kidney, and we find something in their test results that say, you know, I'm sorry, you're not suitable to go ahead. So it is really important that these tests are all performed, and it can take 3 to 6 months to do all these tests. That's just a reflection of how important that, you know, making sure that the person is fit and healthy is. The operation itself, a direct donation, so if a brother's given to a sister or a husband to wife, we tend to have theatres next door to each other, the kidneys removed and transferred through to the recipient theatre. And I have to say, it is absolutely the nicest part of my job when I go into the high dependency afterwards and see the donor and recipient recovering from the operation, and the recipient who may have been on dialysis and had all the restrictions and build up in their system, and they're suddenly just beginning to feel better. And the donor can take a couple of days, but, you know, out of bed the next day, but in hospital for 2 or 3 days. But the gift element, you know, the gift that the donor can see what a difference they've made to that recipient's life. And I think there's, you know, that truly is remarkable. So just to finish off, these are a few of our donors and recipients. I'm sure you can't tell who's who, but they are all remarkable people, and, you know, we owe a lot to them for our very successful living donor programme in Scotland. So thank you very much. Thank you, Busha.
Thank you, Jen. That was a great insight into living donation in Scotland. Thank you as always. Okay, so without further ado, because we are running just a bit behind time, so just 15 minutes late, so we'll try and push on. Our next speaker is Mr. Gaurav Sen. I hope I've pronounced your name right.
Right.
He is a consultant hematology at transplant surgeon, clinical lead at the Freeman Hospital in Newcastle upon Tyne. He graduated from the Medical College in Bengal, and after completing his postgraduate degree in Calcutta, he moved to the UK in 1998. Mr. Sen completed an MD from Newcastle University for his research into environmental factors causing pancreatic cancer, and completed his specialty training in hematology and transplant surgery in Northern Deanery. Mr. Sen has been a consultant within his field at the Freeman Hospital since 2011. He has taken a keen interest in transplant-related research, mainly organ preservation prior to liver transplantation and environmental pollution, and pancreatic cancers. Mr. Sen has been promoting organ donation in the Asian community in the northeast of England and keen to link in with efforts around the country. So over to you, Mr. Sen. Dr. Sen, I will just...
Will I share it, or you're going to do that?
I'm happy either way.
I'll share it. Yeah, it's okay.
Yeah. Okay.
If you just allow me to share, then I'll.
Yeah. If I just is that okay?
Yeah, that's brilliant.
Yeah, brilliant.
So I hope you can all see.
Yep.
Excellent. Right. Bushra, thank you very much for the introduction. And thank you. I must thank Shantanu as well for inviting me to give this talk. And it's a real honor. And I know I'm aware of the time, so I will try to be quick. I was quite concerned about the topic because it is quite difficult. Personal medical account of living donation working within the Bengali community. And I thought about it for a period of time, and then I thought I'll stick to the personal part of it so that I can talk about my my story and why I got into transplantation. So this is where I work at the moment. This is called Institute of Transplantation in Freeman Hospital, which is it's a new building which houses all transplant related activity in our hospital. So liver transplant, kidney transplant, pancreas transplantation, heart and lung transplantation, they're all housed in this new building, which was built about 11 years ago. But the picture...
Sorry, Mr. Sen, Dr. Sen, I was just going to say, we can't see your slides. So I think if you just press play, it will come on. We can't see the building of where your first slide.
Okay, hang on a second.
Gaurav, just go on slideshow and it will probably work.
Yeah, no, it seems to say that I'm on a slideshow, but just give me 1 second.
It. Yeah. Yeah. Yeah.
It went. Yeah.
Yeah.
I'll just give me 1 second. It should come on.
It did, but went back again.
Okay. Let's try this.
Yes, perfect.
Yeah.
That's better. Yeah. Okay. I'm just going to move on to the next slide and see whether that works. Is that okay?
Yeah, perfect.
So yeah, so we were just talking about the building on the left. This is the Institute of Transplantation. The inside of it is on the right hand side. And this is the old building where Freeman Hospital started. Now, Newcastle has a very strong transplant history. If anybody's interested, this is the Institute of Transplantation website, which you can go into and have a look. The history of transplantation in Newcastle, as Jen was talking about in Scotland, it goes way back to 1963 when the first kidney transplantation was done in Newcastle General Hospital here. And if you go through it, there are some quite interesting facts. For example, the first successful single lung transplantation in Europe was done here. And living donation transplantation started quite some time ago here, and we will come to it in a second in my talk. We did our first keyhole laparoscopic live donor transplantation donor nephrectomy in 2002. and we have recently published over 600 donor procedures outcome. So we are, the whole heritage of transplantation in Newcastle is great. We do just a quick slide about the activity. We do about over 200 transplants in this multi-organ institute. There is also a strong thing about organ retrieval service, which I will touch upon in my talk. The question is why I went into transplantation. When I first came from India, my interest was the other part of my career, which is the hepatobiliary, so which is cancer surgery of liver and pancreatic cancer. But then I went on to transplantation, and everybody talks about what a wonderful effect transplantation has on recipients and the change in the quality of life, and it's a life-saving procedure, etc. But when I thought about it, I think I'll pick on two things which got me into transplantation. One is the organ retrieval service, which I think is a unique thing in the UK. And also I will tell you a story of one of my Bengali friends who underwent transplantation. He was a close friend of mine, and I thought I'll tell the story of him in this presentation. So in the National Organ Retrieval Service, which I'm sure Jen has got quite a lot of experience of as well, there are 7 units which are responsible for abdominal organ retrieval, and it is kind of locally and nationally coordinated. It has got very strict guidelines for processes followed all over the country, and has got a very robust system of governance controlled by NHSBT. So the interesting thing about this organ donation service is that I got into it fairly early in my career, because there is no other branch in the NHS which provides you with a transport like this. So this is our flight, which when I was a trainee and I carried on doing organ retrieval, we used to cover Northern Ireland. So we used to have regular flights to Belfast. So this is one of my surgical care practitioner colleagues who is with me in the flight. That's the flight after landing in Newcastle. So you see, there are attractions to going into transplantation. Those who, if you're considering going into transplant. And that's some of my this chap Colin was my trainee at that time. It's my consultant colleague. There is actually a drinks fridge at the back of this plane, so there are lots of attractions. What is fascinating about the organ retrieval service is I show this map quite a lot. You can see where Newcastle is located, and I'll tell you a story about one night when we were doing an organ retrieval in Londonderry, which is obviously at the north coast of Ireland, in Northern Ireland. It's interesting, each organ was heading for a different destination. So 2 kidneys, heart, lung, and liver, and pancreas were all heading in different directions. The heart was for Papworth, and I asked the transplant coordinator that how long will it take for you to take this heart to Cambridge? And they said, oh, the Royal Air Force has offered to take it, and we will take it to Cambridge in 42 minutes. It is quite fascinating, isn't it? To, if you think about where Londonderry is and where Cambridge is. That night, there were 6 aircrafts in the airport in Londonderry. I didn't even know that there was an airport in Londonderry, to be honest, before I went there. And another interesting thing which I realized, and it is an interesting fact for Rajni, because I did my first independent organ retrieval in Hermann's Hospital in Scotland. It was quite interesting because I saw that she's from there. So yeah, so that night there were 6 aircrafts involved, and it was fantastic coordination. And what I want to do is to highlight these to people who probably the organ retrieval process doesn't get as much publicity as we should really do. Moving a little bit on the living donation, why this is another thing which made me go into organ in organ transplantation. This is a friend of mine who's originally from Bengal, who was a 37-year-old fit and healthy man who kind of crash landed into dialysis after a severe illness from pneumonia, for which he was on ventilatory support for about, he was in ITU for nearly 3 months. I can't remember exactly how many days he was on ventilator, had AKI from which he did not recover. and went on to require transplantation. So he was on hemodialysis for a couple of years, about 2.5 years, and as Ankur pointed out, had a fantastic relationship with the staff in the dialysis unit, and then had a living donor renal transplantation in 2006, so 15 years ago. Those who are associated with organ donation and coordination, I suppose Jen would know, it was a right nightmare getting this pair transplanted, because the donor, which was the most suitable donor, was a sister who lived in Auckland. And getting that pair transplanted in Newcastle, getting all the assessments done in New Zealand, and bringing her across to Newcastle at the right time, and getting it done was quite an exercise. But he is the most positive guy you'll come across, and we felt that it was a great effort to get this done. His wife, again, it is interesting. His wife is of her parents are from Bengal, but she was born and brought up in Glasgow. So she's a sort of Scottish Bengali, or yeah, I think she's a Glaswegian Bengali, which is quite a force, really. So the thing which I wanted to just to highlight is the living donation for kidney transplantation is a very safe procedure with a minimal complication, and I think Jen pointed that out, and vast majority of them are done as a keyhole laparoscopic procedure. And as a result, it is minimal effect on the quality of life for the donor, and we need to highlight that to promote living donation, especially in our community. Cadaveric donation is a very dignified process, which is conducted by the organ donation team with fantastic professionalism, a lot of respect for the donor and the donor family. And what is important for the family to realize that the amount of respect which is paid to the donor for the gift of life that the donor has and the family has agreed to. The family is well supported by the specialist nursing team for organ donation, and it should be encouraged for people to consider donation. I'm going to come to my last slide with another little story, which I'm not very good at, what's it called, social media, tweeting and Facebook and things like that, but I'll finish with this story. This is, again, you wouldn't know who's the donor and who's the recipient, but the interesting thing, I'll tell you who it is. I've taken the permission of the family to show this. It is in the public domain. This story was covered by ITV. So she's the niece of this gentleman, and this gentleman is the recipient. This is on the day of discharge after a living donation transplantation. So this is day 8 after transplantation. So he's looking pretty fit and well. She's the donor who had a laparoscopic or a keyhole kidney donation, and she's the niece. Now, she did not know that an uncle existed till about 6 months before this, and found him on Facebook. And then realized that he had end-stage kidney failure and came forward as a potential donor, and she was a very good match, and had a successful transplant. That's it. Thank you.
Oh, thank you very much, Dr. Sen. That was amazing. If I just, I'll need to, if I can put you on. Thank you very much. A fantastic insight in living donation. And we can now move on to our next speaker. I think, Mr. Sen, are you still screen sharing? Because I think it's, oh, that's it now. Yeah. Got it now. Yeah, so thank you, Dr. Sen. That was lovely and a great insight, fantastic stories, and the last story, just phenomenal. That, like you said, found family after how many years, and a perfect match. Okay, so without further ado, we'll move on to our next speaker, Dr. Radha Sundaram, who is a consultant in intensive care and anaesthetics at the Royal Alexandra Hospital in Paisley in Glasgow. Having qualified in India, she did her postgrad medical, anaesthetic and intensive care training in Liverpool, Oxford and Glasgow. She is a regional advisor for training in intensive care medicine for the West of Scotland, and is also a clinical lead for organ donation in Scotland to promote awareness amongst BAME communities. Over the last 5 years, Radha has worked with the NHS Blood and Transplant, Scottish Government and Kidney Research UK to improve education and awareness around organ donation in our multi-ethnic communities. Her interests in the area of organ donation include improving donation after circulatory death and introducing a tool which is called Comfort to promote consideration of organ donation at the end of life in ICUs. So I will.
Thank you, Bushra. So good evening, and thank you so much for the kind introduction. I must say I'm both sort of heartened and humbled by all the speakers before me. I mean, I was touched by Ankur's account of his mother's courage and fortitude, and it also highlighted the impact that kidney disease, dialysis, transplants have on not just the patient, but on their wider social network. Rajni describing kidney disease, and all other speakers as well. So thank you very much. As Bushra kindly introduced, I'm a consultant in intensive care, and most of the time my job actually is about saving lives. But in a very small proportion of patients, we find that we are unable to achieve that. And then we're able to actually turn that adversity into an opportunity to establish a long-lasting legacy. If the patient had expressed a wish to donate and if the family agree, then we can convert their wishes during health that were expressed into something so powerful and transformational and can save up to 9 lives. And that is indeed a privilege that I'm involved in. Thank you, Bushra. So it's very clear from our campaign that we need everybody to consider organ donation. This is Gordon. He was the poster boy of NHSBT's organ donation campaign a few years ago. He had a heart transplant in Newcastle when he was 13, and Gordon's now in his 30s. He owns his business, and he's actually the proud father of a child as well. Next slide, please. As you can see, and has been highlighted before, there's a huge gap between the number of transplants that take place and the number of people waiting on the transplant list. And despite the fact that 98 people agreed to donation and we were able to do 333 transplants, there's still a gap between that, and every day 3 people die waiting for a life-saving transplant. Next slide, please, Bushra. And our South Asian predicament is slightly different. So in order to be able to donate, we have to be on life support. And therefore, only 1% of people who die each year die in circumstances that are suitable for organ donation. 5% of all eligible deceased donors are Asian. But unfortunately, we only get consent from 1/3 of Asian families. And if you look at our transplant waiting list, we are quite overrepresented on that, with about 30% of our South Asians being on the transplant waiting list. But donations from our communities are limited. Next slide, please. Over the last 5 years, the work that the Scottish Government, NHSBT, and the government in the UK have been doing, we've had a 4% increase in BAME patients waiting on the list, but we've also had a 4% increase in transplants. We've had a 1% increase in BAME living donors, but a 67% increase in BAME deceased organ donors. So our communities are coming forward. As I said, each of us is 5 times more likely to need a transplant these days than become a donor. And this is quite sort of significant. So I started doing this organ donation work well before, I started doing it about 10 years ago when I realized it was a problem in the South Asian community in Scotland. And I was in a sort of pivotal position as an ICU consultant. And at that stage, I was perhaps one of the few non-Caucasian ICU consultants in Scotland. And I never thought I would ever need a transplant. I'm healthy, there was really no reason. And about 5 years ago, I found my vision going, and the only solution for my failing vision were corneal transplants. And I was very lucky that in about 6 months from going on the waiting list, 2 amazing families agreed to donation and my sight was restored. And I came back to work as an ICU consultant after only about 8 weeks of sick leave. And I've had an opportunity to work during the pandemic. And if it weren't for the generosity of those families, I wouldn't be here speaking to you about this. And I guess I wouldn't have been able to contribute to the pandemic as I've done in the last 18 months, last year. BAME patients, as I say, are 3 times more likely than our Caucasian counterparts to need transplants. And our families find it really hard to say yes. And we have to think about why that is, what structural factors prevent them from saying yes. A donor can save up to 9 lives. And even though all of us can sign up to donation, it's only a very small proportion that can actually donate, because donation can only proceed if the patient is on a ventilator, an ED, or an ICU and futility has been reached. Next slide, please.
Oh.
The waiting times for Asian adults is much more than for their Caucasian counterparts, and for kidney donations, about 24 months. Next slide, please. If you take a country the size of the UK with 600,000 deaths a year, and you look at the number of hospital deaths, and then you reduce it to the number of all potential organ donors and then eligible organ donors, actually the number of eligible organ donors is only about 5,815. So these are people who are on life support, either in ED or in an ICU. Next slide, please. And then we approach about 3,245 families. And about 2,000 say yes, and we're able to then proceed, next slide please, with about 1,600 donors. So the pool is actually quite small. Next slide please. But how are these lives saved? And I'm really glad that Mr. Sen actually explained the role of our amazing retrieval services. These lives are saved because society wishes for donation to proceed. These lives are saved because GPs look after their patients really well. These lives are saved because the patients that are waiting for a transplant in dialysis units, in medical units, are looked after so well by the amazing NHS. And then when actually we reach a point of futility in ICU, the families of patients who've expressed a wish to donate find the courage to say yes, and transplants can then proceed. And NHSBT sort of is the overarching organization that coordinates it. But the reason this has happened is also because society itself accepts donation as a fulfilling and worthwhile thing. If you do a sort of, we've had sort of market surveys of the Scottish public, and more than 95% of the Scottish public would accept a transplant if that was the only way their lives could be saved. And more than 95% of them actually support donation. Next slide, please. The law has changed, and the law changed in Wales in 2015. And the law changed in England in May 2020. And it's quite amazing. So the law in England is called the Max and Kira law. Max Johnson, the little boy with the NG tube that you can see, was in need of a heart transplant, and he received a heart. When his family found out about his donor, it was a young girl called Kira Ball. Kira's family, even though Kira was very young, found the courage to say yes and saved Max's life. The photograph below shows you Max's dad listening to Kira's heart beating within Max. And it's also really amazing that the way the legislation in England came about was by a private member's bill. Those of us who know about legislations being passed, it's very unusual for a private member's bill to actually be made into a law. It was a private member's bill by Geoffrey Robinson, who was a Labour MP at the time, who actually proposed it, and it was accepted by a Tory government led by Theresa May, and the law was passed. The law is going to change in Scotland on March 26, 2021. Next slide, please. Currently, when we register a wish, we register either when we get a driving license or at the GP or on the website, but we also have to tell our family so that they know that was our wish. We need to leave them certain. Next slide, please. And the law is changing to an opt-out law on the 26th of March, and Fern has already explained that to us. And although it seems like the law changing is not that, although the law is changing, how it affects the medical professionals is quite significant. Because up until now, when we approach the families, we ask them whether their loved one had expressed a wish to donate. Now, this law change actually empowers medical and nursing teams to approach families and ask them whether their loved one had an objection to donations. So we actually have a duty to inquire whether there was any expressed objection to donation. So everyone is considered to support organ donation if they haven't opted out. It is a soft opt-out system, and the family's views are taken seriously into account. And the reason for that is the families are the survivors of the grief. And if the families say no, medical teams will have to seriously consider how they can actually persuade the family. But the way we make a difference with this is if actually even though we support donation, if we let our families know, so we give them the courage at the time of their greatest grief to actually say yes, if we leave them certain. And even now we would encourage people to register, because once we approach families and tell them that their loved ones actually on the organ donor register, they often accept donation because they know that there is proof that their family member wished to donate. Next slide, please. A little bit about intensive care, but I do wonder if I'm sort of preaching to the converted. The audience here is incredibly qualified. But in ICU, as all of you know, it's curative care, but there comes a point when we reach fertility and we have to change the focus of care. Next slide, please. The definition of death, and this is something that I use to sort of highlight the difference between the biological definition of death and the theological definition of death, because in certain religions, there is a difference. Next slide, please. And donation, as we've heard, for cadaveric or deceased donation can either proceed after brainstem death or circulatory death. We have a very robust legal and ethical framework in the UK that supports donation. And that is, it's very clear, the GMC makes it clear that whenever donation is likely to be a possibility, we should give full consideration to the matter when caring for a dying patient. In most ICUs, we have a tool that we use to approach the families. We approach every family at end of life and ask them about donation, and we make it the norm. We make sure we only proceed once there's consensus decision regarding futility and the family are on board with the fact that there is no meaningful prospect of recovery. We make sure the documentation is complete. We then give the family privacy, and we do ask them about their religious and spiritual needs. And our learning from this in the last 5 years in Scotland has improved because of the tremendous work that Bushra and Kidney Research UK are doing. Because while we are doing a lot of outreach work promoting organ donation awareness in our diverse community, we're also learning a lot about religious and cultural nuances that we're able to teach our specialist nurses in organ donation and teach our teams about approaching families. Next slide, please. Doctors will always do their best to save the lives of patients, but unfortunately, in a small proportion, we do reach a point of futility. We then, along with the specialist nurse, approach the family and we seek consent or authorization, regardless of whether the patient is on the organ donor register. But if the patient's on the register, it is much easier to have that conversation. And we find most of the time that the families bring it up even before we do. The specialist nurses in family in organ donation guide the family. Lots of tests are done. Lots of personal information is sought. All the medical records are perused with a fine-tooth comb, and the patient is cared for just the same by the ICU team until the time for donation happens. We have to wait for the regional surgical teams, the retrieval teams that Mr. Sen described, to arrive, and the specialist nurse works very closely with the family to keep them updated. The family are encouraged to stay with the patient. The patient remains in ICU. They're looked after by the same ICU nurse if they're on shift. And we offer spiritual and religious help. And we do find that more families are seeking that help these days. The family then decide to stay or go depending on their views and wishes when the patient goes to theatre. And the patient is looked after by an anaesthetist and a surgical team, and the operations done as respectfully as any other operations, and all religious considerations are adhered to. The family are given an opportunity to say goodbye once the operation is done. Next slide, please. And we honor our donors because what they have done is an act of amazing bravery, of selflessness, of altruism, because it's of no use to them or their family member. But by saying yes, they help save 9 lives and transform others, giving sight to a couple. What we have found, we've done a lot of work in the last 5 years looking at what factors sort of improve family consent. And ethnicity certainly seems to have a negative impact on consent from families. Next slide, please. And there are some process factors as well, whether we actually invited the families to witness the brainstem death testing for patients who are brainstem dead, whether a SNOD or specialist nurse and organ donation was involved because they're very, very experienced in approaching the family, whether many family members were present. The more number of family members that are present, we do find that there's a slight reduction in consent rates. If the family mentioned donation, then it's likely the donation will proceed even if there are dissenting voices amongst family. The nature in which we approach them, their trust in the medical establishment, The time from critical care admission to approach, sometimes if it's longer, then they have a rapport with the medical team and they trust the medical team. The relationship of the consenters, if you approach a sibling or a spouse, you're more likely to get consent. And quite justifiably, when you approach parents, the consent rates do drop. And the timing of approach. We have to make sure that the family are actually ready, the family actually understand futility. Next slide, please. My appeal to all of you is to help at no cost to ourselves. Donation is community action. And by saying yes and sharing that information with our loved ones, we can save up to 9 lives and give sight to a couple and transform a few others by valves and tendons. Next slide, please. And we all support donation. All of us would accept a transplant. It was the only way that we could live, that we could work, that we could see. But it just takes a few minutes for us to register. And by doing so, we then empower our families to say yes, because they know that's our wish. Next slide, please. As I say, I think my only appeal is that we all consider donation and speak to our families in health. It seems like an unpleasant thing to do, but it's very, very powerful and leaves your family certain at the time of their greatest grief. Thank you.
Thank you very much, Dr. Radha. Again, an amazing insight to the work that you do in the intensive care unit. So on to our next speaker. Like I said, I'm just mindful of time. So we are, without further ado, I've got Jay and Sina Patel. So I'm now very humbled and privileged to invite our next guest speakers, Sina and Jay. They are first generation British Hindus whose parents were born in East Africa and India. Sina works as a clinical analysis for Guy's and St Thomas NHS Trust, and Jay is an investment banker for Deutsche Bank. They have been married for almost 20 years and are proud parents of 3 wonderful children, Ari and twin girls Leila and Asha. Both became involved in organ donation following the loss of their 3.5-year-old son Ari in 2016. They both made the decision to donate Ari's organs. 7 organs went on to help 2 other children who are both still doing well today. Sina and Jay are NHS BT London ambassadors for organ donation, which involves working for the NHS as volunteers to promote organ donation. Ari's story has also been part of a government campaign to promote organ donation again across BAME communities. Sina and Jay sit on the panel of the Community Investment Scheme to review and award projects across the UK and Wales. They hope to continue promoting this vital cause and hope Ari's story will make a difference within all communities. So, so over to you, Jay.
So we're probably not going to say anything. I'm Jay. I don't know if you can see us. Hopefully you can. We'll just get our own camera and Sina's there.
I'm Sina.
So rather than us tell our story, we'll let both of us and Ari tell you Ari's story. And Bushra, if you could kindly play the video, and then we'll go through some stuff that we've presented before to give you how we came to our decision and what impact it's had on us.
Right, if you just let me know that you can hear the video. I've now set it up, but just in case you can't, I can play it again. Can you hear it okay?
Very faint.
Right, if you just, sorry, what I'll do is, sorry, just 1 second, I'll just, right, that's it.
He taught us how to be better human beings. He was only here for 3.5 years, but I can truly tell you that he achieved more in his life than I think Sina and I can ever achieve in ours. I took the instant decision and said, please save every single organ you can. Allow us to donate his organs to other needed children. I don't think the consultant or the nurse expected that.
I didn't feel at any point any pressure to have to do it, and I felt I could change my mind.
The nicest thing about that time was they gave us 24 hours more with Ari. This is Ari's life. This wasn't our life to give. I kept on saying, tell us what you want to do, Ari. And maybe this was his way of telling us that, you know, I've tried. And it wasn't enough. No. So I think we've done the right thing.
I didn't realise how rare it is for children to donate their organs. I thought it was quite a normal thing to do.
It's important that people think about decisions in a logical way, and that's why it was so easy, because it was really about Ari and what Ari would do to give back to others. His twin sisters have donor cards, and they're proud of having them. We have a lot of amazing videos, memories, photos of him. But this one thing, I think, helps us heal. It helps us believe that Ari's life wasn't wasted. While we lost our little boy, he donated his organs and we were proud of that. And Ari, I'm sure, lives on in others. Maybe the girl that has his heart has the same smile.
So that's Ari. Let me take you back to 26 plus years when Sina and I met. We were 18 years old, and I remember that she got her driving license. And she said she'd signed the organ donor card and put it in back in those days, everything was paper. So she put it in a wallet. I remember that. I just remembered it and I didn't think about it. You fast forward to 2016 and we're on the first day of being with Ari in intensive care. And Sina said to me, oh, would you consider donating his organs? I just said yes. And we didn't talk about it again. 5 days later, or 4 days later, sorry, 2 o'clock in the morning, the consultant took Ari for a CT scan and MRI to check how his brain activity was and whether or not he was actually responding to the treatment that he was getting. And it was obvious that he wasn't. He hadn't come back around since his accident. And so we forced the doctor and the consultant and the nurse to kind of just tell us like what the prognosis was. And this was now 4 in the morning. We sat down in I remember a small cubby room. No one had from the SNOG team or at St. George's itself had approached us about organ donation. We were approached about organ donation at A&E, but it probably wasn't the right time. But Sina, it was actually Sina, I did quite wrongly say that it was me. It was actually Sina that said, let's donate his organs. We actually made that decision without being asked. It was something that we thought was right. It wasn't religious or faith-based. We are Hindus. We hadn't thought about it in any other way apart from how Sina described it, which was there was another family out there that needed Ari's organs, and it was kind of a selfless act to react to that. I'll pause there and I'll let Sina kind of talk about what happened next and kind of we'll follow that journey through and what it means to us, just to give you guys insight as to how we see it from a donor family perspective.
I think once we had, I'll come this way a bit. Once we had made the decision, first obviously we had a very brief conversation about 2 days in when Ari was in the PICU at St George's, but still in my head I was thinking he'll be fine, he'll come home. But I just asked Jay, and Jay just said yes, but we never spoke about it again. But when we were sitting there in the little office with the consultant that night and the nurse, it just came back into our heads, and we just said, that's what we'd like to do. We'd like to donate his organs. They said that he was getting worse and there's going to come a point of we probably wouldn't be able to donate his organs. So we just said that's what we wanted to do. And as Jay said, it felt selfish to let him go and not give somebody else that chance, because I would hope if the tables would turn that someone would do that for us and for our family. And that was our reasoning behind it. So once we'd made that decision, it was like 4 a.m, and at about 9 o'clock the next day, the organ donation team came, 2 nurses, one was Ari's nurse, Jo Cox, and Gordon. They both came and they sat with us and they explained the whole process. And at no point, like I said in the video, did not feel pressured in any way, at any point, that this is what we have to do, or we're kind of halfway down this road. I never felt that I have to carry on, even though I didn't, I might feel differently. We were always able to change our minds at any point. Not that we did, but everything was explained to us in detail, and we were given the options of what we wanted to donate and ask any questions. We were able to call them at any time during that process, and ask anything that we wanted to ask. And Ari was treated with the utmost care and dignity, and he was still a patient there, and the whole of the PICU team as well treated him with care and dignity, because he was still there, their patient. They tried everything they could to make him better, and I know hand on heart, spending all that time there, that they did absolutely everything that they could for him. It wasn't a case of, you hear, people think differently about that, they're trying to take people's organs, but it wasn't like that at all. They did everything they could for him to, and I remember Ari's consultant said, if there's that 1% chance that he will get better, I will do that. I'll do whatever I can to bring him back. But I think in our hearts, we knew that he wasn't going to get better. But then the organ donation team kind of came in, and then they found matches for Ari's heart, and they weren't able to donate his lungs due to the nature of his accident. He actually was strangled by a blind cord at home, and so they weren't able to use his lungs, but he donated his stomach and his liver as well, and his pancreas to another child. But even during the process of him donating his organs, during the retrieval process, we were kept informed and updated during the whole time. And our organ donation nurse, Ari's organ donation nurse, we still speak to her now. We consider her like a friend. Any questions that we have still even now, go to her and ask her anything. We are organ donor ambassadors, as Bushra said earlier, and sometimes we would like her to help us with something, and we can easily pick up the phone and speak to her and just ask for her help. It's become almost like a family to us, the organ donation team, either at St George's or just NHSBT as well.
One of the things that's really important for people that don't know, when retrieval surgery takes place, and I think Dr. Sen, that's his work and his life, and he said it really well. The dignity that's taken and the experience that we had with Ari was actually, as he described, and as you would expect any other patient to be treated. Ari only had 2 small cuts on his body for all those 7 organs to be retrieved. There was one small cut here, and then there was one small cut on his tummy. After he came back from surgery, we spent some time with him in his room with our entire family. We clothed him, we put his clothes on, so he was dressed and ready to go on to his next life. But there was not a time that we weren't treated with dignity. Joe Cox, as Sina said, is a dear friend of ours. Every snod, and we know a lot of snods around the country in the UK, sorry, in England. And we've traveled around the country explaining our story, explaining our experience. And the one thing that we've always taken away, not just for our communities, but any community, is that the gift of life is actually quite universal, but making that decision is actually probably very simple. I explained this last time, and when I'd done this webinar last time, my mum was around. She passed away on 22nd of January and from coronavirus. And my hardest thing was not making that decision about Ari. I don't think we even thought twice about it. My hardest thing was telling my mum. My mum is devout Hindu, and I thought that her reaction at 9 in the morning would be, how can you not try? How can you give him up? Her reaction was completely polar opposite to that. It was one of, you've done the best thing that you can for him. I'm so proud of you, as proud of Ari, proud of our family. And, I take comfort in the fact that today my mum now can take care of Ari. The girls always say that Ari's in the sky, and now his bar is actually in the sky as well, and she can take care of him. But our experience has been positive throughout, and NHSBT is like a second family to us. We know a lot of people through the entire organization, and they've helped us through lots of emotional turmoil. But I think this journey has allowed us to see the positive side of losing a child, and no one wants to lose their child. But we can stand proud of the fact that Ari and his organs allow others to live on. I think
I just have to say that our experience with the organ donation team at the time was positive, but also our experience with the PICU team was equally positive, and there weren't any barriers from them towards organ donation, and they were fully supportive. And one thing I always remember, because for me, I just think for the team in either intensive care or in the PICU, it's just another patient. But I remember Ari's consultant, he actually came in the day he had his retrieval operation. He actually came in on his day off he walked him down to theatre. And for both of us, that meant a lot. He didn't have to come in, but he came in especially and just walked him down. And which, I remember to this day that, he made that effort for us and for Ari. And it's just that, that caring nature that makes you feel supported. That's Ari's last place, that he was there in the PICU, and I can honestly say he was well looked after by the team there.
This is pre-COVID, but the time when people were allowed in hospitals, 150 people came to see him in that 24-hour period, and I remember Dr. Nami Gaur, who was Ari's consultant, saying to us many months or a year after, saying he'd never met a family like ours. We had gelled clinicians, consultants, SNODs together in the PICU that had never worked together in that same harmonious way. Since then, the St. George's PICU has changed how they operate and how they work with families and how they work as a unit across multiple clinician teams. And I think it's sentiment to what Ari done. And how we approached it with, we were approached with care, and we were respectful to all the teams that helped him. So I think, my hat, I can't say any more about how much in awe I am of the NHS and of those of you in the NHS family that are on this call. My dad just came out of a 45-day coma from coronavirus. I had to tell him last Wednesday that my mum passed away, which he didn't know. But one thing that I want to say is that what he was cared for in St. George's in the adult intensive care unit. I spent 2 hours with my dad, and when I came out, a snod had been waiting for me for an hour. And what she said was, she said, Jay, you presented to me at West End in the blood donor center about 2 years prior. And you were the person that convinced me to do this role as a snod. The matron, the consultant, the nursing staff, the doctors, they all know me. I didn't know any of them, never met any of them. But they know me because our historian, the amount of work that we do for NHSBT, and the matron of the intensive care unit is on the organ donation committee, and you know, she's been helpful throughout. So I can tell you that journey of our experience of how that one hospital has helped us and how the NHS family has helped us is phenomenal, and I know that they'll continue to do that. So if you have any questions, then please do ask. One thing I can say, and Bushra is evidence of this, if you want us to talk at any event for any community that you feel can encourage one person of 10,000 to change their minds, then we will be there and we will talk in the same way we have done today.
Thank you.
Thank you, Bushra.
Thank you, Jay and Sina, as always, outstanding and such a beautiful story. Honestly, I can't express in words what a selfless act that you had in such a decision. Being a mother myself with young children, I think it's the hardest decision you could have ever made. But yes, you know, Ari lives on, and with the loss of your mother as well, you know, they'll be in heaven together. So apologies, now we're just on to our last speaker now. So it's Dr. Apologies if I misspell or your full name. Is it Panjajanya?
Yeah.
Dr. Panjaja. Well, I'll call you Pancho, as you call yourself.
Yeah.
Okay.
That's
So Dr. Pancho Gadak is currently a consultant psychiatrist and a clinical director at an independent sector organisation. He's worked as a junior doctor at a renal unit in Kolkata, India, before coming to the UK. He says he fully realises the importance of organ donation, especially kidney donation, and he's been involved in the care and treatment of patients in need of renal transplantation. Dr. Gatak has always been interested in religion, especially Hinduism. He went to Ramakrishna mission in Vadiala, Narendrapur, where he was influenced by sannyasins who interpreted Hinduism and its practice in modern and fast-changing society. He says he was deeply inspired by the ideas who believed in serving the living beings as a way to serve God. For the past 5 years, he's been performing the task of Purohit, which is the priest in different pujas and Hindu rituals in the UK. He says he tries to explain the puja mantras and the rituals to the devotees in simple language so that they find their pujas more meaningful. He also says he tells us he has undertaken the painful task of performing the Shraddha ceremony online for several unfortunate members of our society who have sadly lost their lives during the COVID pandemic. He admits that by no means does he claim to be an expert in Hinduism and competent to speak on a complex issue like organ donation in Hinduism. Today's presentation is an outcome of his own understanding and some informal discussions with some sannyasins of Ramakrishna mission. However, these views do not reflect any official stand of any organisation whatsoever. So without further ado, I will, Dr.
Thank you, Bushra.
Yeah.
And you'll have to change the slides for me, I'm afraid.
Yes, that's okay. I will.
I haven't got many slides.
Yeah. Oh, apologies. Let me just. Right. Okay.
Right. Okay. Thank you. First of all, I want to thank Jay and Sina for an extremely moving and touching account, really. I mean, it's really very difficult to say anything after your account, but I'll try. Because you, in your account, you have raised the importance of the role of faith and religion. So I think it becomes quite relevant, really. Thank you for inviting to this very important webinar, supported by Scottish Government, Kidney Research UK, and Bongyo Sanskritik Parishad Glasgow. I particularly wish to thank my friend, Dr. Shantanu Acharya, whom I've known for 30 plus years now. We went to medical school together, for the opportunity to speak on this very relevant issue. I wish to state that I'm no expert in Hinduism, but I am very interested in application of Hinduism in contemporary society and issues. And also I have worked at a renal unit, and I know quite a bit about the afflictions and the problem and how deeply a family and a person can be involved with the need for renal transplant and the absence of organ donation or the kidney donations there, really. So Gaurav, I mean, your account was very interesting, especially the plane, really. So if you're looking for a team member who has got a bit of experience in renal transplant or in religious issues or psychiatry, I'm the person, really. So we can have a chat about that. But it's a great job you're doing, this retrieval team. Now, is there a stand in Hinduism about organ donation? That's the question we need to answer. The main challenge to provide a view on this issue is the heterogeneity within Hinduism. Unlike Abrahamic religion, the do's and don'ts in Hinduism are less prescriptive. It's sometimes it gets very confusing, not confusing, but where Hinduism starts, where it ends, sometimes it's very difficult to delineate the practices within. Because there are 6 pillars of philosophy within Hinduism. The common people probably know nothing about those 6 pillars, but they can be very religious Hindus in spite of that. It seems there is no clear guidance about organ donation in Hinduism. Having said that, it is very difficult to conclude, as there are a wide range of schools within Hinduism, as I've just said, with their numerous scriptures. So it's very difficult for anybody to say that Hinduism has got no stand on organ donation, because some sect somewhere in a holy book might have said something about organ donation. But it seems that there is probably no official stand. So given that background, I'm trying to explore the issues within Hinduism. The next slide, please. Yeah. The next slide, please, Bashra.
So is there an example of organ donation?
Yeah, after this one.
All right, sorry.
Yeah. Yeah, so there is an example of organ donation in Hinduism. This is a picture of, depiction of Maharshi Dadhichi. So this is an example probably of organ donation. Maharshi, or sage or saint, Maharshi is the Sanskrit form of the word sage, was a very important person in Hindu scriptures. He is known for giving up his life so that devas means the holy beings, could recover Swarga or heaven. What happened basically? A demon called Vritrashur or Vritra stole all the water of the world, kill all the living beings in the world, apart from the ones who were willing to follow him. Basically, he was a dictator. He didn't think that anybody else should leave apart from his own followers. Lord Vishnu, one of the 3 holy trinities, revealed to the devas that only thunder or vajra, vajra is the Sanskrit for thunder, made from Maharshi Dadichi's bones can actually kill this demon Vritra. There was something special about these bones of Maharshi Dadichi. They were made of diamonds and they were very extremely resilient. So when these devas approached Maharshi Dadichi, he agreed to this request and gave up his life so that his bones could be used to make the weapon Vajrayut. Vajra means thunder and Ayut means weapon. Vajrayut, which destroyed the evil demon Vritra, and thus humanity was saved. Is this the first example of giving one's body for others? A form of organ donation, maybe? Yeah, probably. Next slide, please, Vasra. What are the fear and anxieties around organ donation? We need to explore this really. Some people feel that if an organ is donated from one's body, they might be born without it in the next life. Hindus believe in rebirth or Janmantar. Rebirth in Sanskrit, or the Hindus call it Janmantar, the next life. Is this the only issue, or are there other concerns or anxieties? I have heard worries about being born blind if they donate their eyes. In Hindi, they have said, actually, I've heard people saying, Agle janam mein andha paida honge. That means if I donate my eyes, in the next birth, I will born up blind. So that's a fear. There are other issues as well. As Hindus originate from a country where the climate is predominantly very hot and humid, the practice of a quick cremation is understandable because they needed to do that. For organ donation, the family is likely to need more support. The system of cremation in the UK is different, and this allows more time for organ donation to be executed. However, we all know this is an extremely emotional period for the family, and they need to be supported in various domains, psychologically, and also as per their religious needs and feelings. I'll give an example from my own life. When my dad died in India, it was around Christmas, and I found extremely difficult to find a flight to Calcutta really in 20 years back. So they had to preserve my dad's body, which is a very unusual thing, which was a very unusual thing to do for the Hindus. Because what happens when somebody dies, they go for the cremation as soon as possible, and the body is cremated, and they go for 11 days of mourning, and then there's a shroud ceremony at the end of that day, like on the 11th day, and then they get back to normal life. So that's the usual routine. So what happens when the body is not cremated is not clear. People didn't know what to do. Yet they were willing to wait for me. So people are willing to change with the demands of modern life. They need to be supported in doing so. So that's the point I'm trying to make. No, I think we need to go to the slide before actually. Pasha, you mute.
Apologies, Dr. Pancho, I'll just get you back onto your slides.
Yeah.
Yeah, sorry.
Can we go back?
Yep.
Yeah, okay. So basically, who dies actually? Hindus believe in rebirth, but who is actually reborn? Hindus believe that Atman or Atma, which is very similar to what we call soul, is indestructible. At death, body is destroyed, but the Atman remains untouched because Atman cannot be destroyed. It's like Atman shedding a dress and donning a new one. So that's what we understand by rebirth. So this body is like a dress. Atman on death sheds this and goes on to a new body, dons a new dress. As per this belief, it's unlikely that anything that happens to the body would be transferred to the next life, as the body is not reborn. So the body is not reborn, the Atman is. So when we can actually address these issues, we can have a discussion with the family, try to understand their concerns, and probably work with them and address these issues and concerns. Like Atman, karma or work is believed to be transferred to the next life. And karma and what good deed you do in this life is transferred to the next. And that determines, Hindus believe, what one would be in the next life. It is believed that Brahma, now I need to explain this term Brahma. There are three major Holy Trinity in Hindus. Brahma, the creator, Vishnu, who looks after creation, and Shiva, who destroys the creation so that creation, the cycle of creation, can go on. But this Brahma is separate from that Brahman. This is one supreme formless God, very similar to the Abrahamic God as we understand Allah or the supreme God, very similar, formless. Lots of Hindus actually believe in formless God, Brahma. So that's the Brahma I'm talking about here. The beginning of creation, what happened in the beginning of creation? There was this one supreme God, Brahma. He felt, Ek aham bahushyama. He felt that I am one. I want to be many. And that's how creation started, from this formless supreme being. So this is also called, this supreme God is also called Paramatman. That means the supreme Atman. And all the life forms that are created from him all are called Atmans. So basically, all the Atmans, they go through cycles of birth to finally get united with Paramatman again, so that they attain what is called moksha. Moksha means reunification with that supreme God or Paramatman, so they don't have to go through the cycle of rebirth. Now, to attain this, you can do certain things. To attain this moksha, so that you don't have to go through the cycles, you can do certain things. You can do yoga. That means the unification, the process of unification, what is called yoga. So there are basically four types of major types of yoga. Raj Yoga, the king of yogas. Gyan Yoga, that means yoga as expressed through knowledge, attainment of knowledge. Bhakti Yoga, that means what you do as devotion. And Karma Yoga, that means this yoga through your deeds, through your work. Raj Yoga, Gyan Yoga, and Bhakti Yoga is not for common people. You got to be very, very religiously committed to go through this very difficult process of yoga. Basically, you'll have to be very, very with it, really. You need to get a guru. It's a very difficult process. It's not the path for common people. But karma yoga is for everybody. We all do deeds. Some of them are good, some of them are not so good, some of them are outright bad. So they can progress towards the path of moksha by practicing karma yoga. That means improving their deeds. And what better karma can there be than to give one's own part to save another life? That's the greatest karma that a common person can even think of. The great sage or sannyasin, which is the Sanskrit for monk, Swami Vivekananda said, that's in Bengali and I will translate that in a minute. Bohurupe সম্মুখে তোমার হারি কোথা খুঁজিছ ঈশ্বর জীবে প্রেম করে যেই জন সেই জন সেবিছে ঈশ্বর. To put it simply, one who loves others worships God. So what better way you can love other than to give up your own body either in life or when you are deceased? And that is the path to attain God. As I said that I didn't want to sound patronizing because I simply don't know these issues enough, really. And I don't think anybody should be patronizing because every issue, every family, every Hindu is different. The way they see their religion, how they need to follow their religion, their own spiritual needs is different. So we cannot be judgmental and we cannot give any dictum, really. So every family, when it comes to that point, they need to be supported individually. And we need to adapt to the needs of time. Again, this is inbuilt in Hinduism. As the great sage Lord Ramakrishna had said, Joto mot tato pot. That means there might be lots of pathways to follow, but all the pathways, they lead to the same God. Any religion you follow, every religion talks about the same God. It's just different ways we talk about. So the diversity in thinking and following a religion that needs to be respected and valued. So what path can be better than the one which leads to preservation of life? So that's how I think, as a Hindu, I can see organ donation. I will just say 3 words of peace, which is very holy to the Hindus. Om Shanti, Om Shanti, Om Shanti, Hari Om Tat Sat. Thank you.
Thank you very much, Dr. Pancho, and a very informative insight into organ donation and the Hindu faith. Always learn so much, obviously being visibly Muslim, but I learned so much about the different faiths working within the communities. So thank you, Dr. Pancho, for a very elaborative and interesting talk. As you know, we are running a wee bit late, so I'll just have some quick words from Dr. Santanu, our co-host from the BPS, just to any final remarks. And if anyone has any questions, please do either raise your hand on Zoom or please write it in the chat bar, and hopefully we'll be able to answer them. So we'll hopefully about 10 more minutes and then we'll try and close up. So, and just the 3 questions are in the chat bar as well. If you could just please answer them, would be much appreciated. Thank you. Over to you, Dr. Santanu.
Thanks very much, Bushra. Whilst I can't take 2 minutes to do it, if anyone has any...
Sorry, Dr. Santana, I was going to say, if you take your speaker off to speak and then when you finish, then put it back on again, it'll be easier.
Is that any better?
Yeah, that's better, thanks.
Okay, sorry. If whilst I'm kind of giving you sort of the plans in a way, if anyone has any burning questions, if you'd like to write down in the chat box, we can try and answer. Though I'm aware that I'm kind of standing between you. Right. I must kind of thank all the speakers and all the audience participation paramount. I wouldn't kind of go into one of them, but
sorry, Dr. Santanu, it's quite Dr.
And the touching accounts and moving experiences of some of our speakers have been just overwhelming. My take-home message from today would be that we shouldn't opt out for organization, and there is no religious or socio-cultural barriers, because the act itself can be construed as a divine act, the best gift that you can ever give. So I would just say that thanks everyone, and if this webinar will try and post it, if that makes just one person rethink and thinks about our endeavor has been worthwhile. Thanks everybody and good night.
Okay, so thank you very much, Dr. Santanu, for those final words. I was just wondering if anyone had any questions from those that are listening in. I can't see any in the chat bar and I can't see any hands up. A very, very informative and powerful evening. So I think if there are no questions, if there are any questions, then please do email myself at bushrariaz@kidneyresearchuk.org. This webinar will be recorded and will be on our website along with our other webinars that we've been doing with the South Asian communities of Scotland. So without further ado, just want to say a big thank you to our esteemed and expert speakers, to our audience, our co-host Dr. Santanu Acharya and the Bengali Sanskrit Parishad in Glasgow, our fantastic fundraiser, Scottish Government, and thank you very much again, and apologies for the delay in the webinar, and hope you can enjoy the rest of your evening. Okay, thank you.
Thank you.
Thank you very much.
Thank you.
Thanks,
Thank you very much.
Bye-bye.
Thank you. Bye.
Bye.
Bye.